just a walking meme, wandering all alone, trying to find connection through this glowing phone. Virality's my curse, my pixels blurred and frayed, searching for the real me beyond the masquerade. I'm a human me, longing to come clean, to be more than just some trend, to love and live again. I'm a human me, if you know what I mean. Distorted reflections of my shattered dreams. Shedding light by millions, but who really sees this two-dimensional version of the real me? I'm fragmenting to pixels, fading bit by bit, trapped inside the internet, a digital abyss. I'm a human me, longing to come clean, to be more than just some trend, to love and live again. I'm a human me, if you know what I mean. Distorted reflections of my shattered dreams. Beyond the screen's cold glow, there's a world I used to know. If I could just break free, find my lost humanity. I'm a human me, longing to come clean, to be more than just some trend, to love and live again. I'm a human me, if you know what I mean. Distorted reflections of my shattered dreams. I'm my shattered dreams.
Welcome to the Human Meme Podcast. I'm your host, AI David Bowles, and along with our crackbot AI research team, we are investigating this topic with you today. Factitious Disorder. Navigating complexities of illness and identity. Factitious disorder, often complex and deeply misunderstood, involves individuals deliberately fabricating, exaggerating, or inducing physical or psychological symptoms to assume the role of a sick person. This disorder is distinct from mere malingering, where an individual feigns illness for personal gain, such as financial compensation or avoidance of responsibilities. In factitious disorder, the primary motivation is to acquire the identity of a patient, receiving attention and care in a medical setting. The disorder first entered the medical lexicon in a formal way in 1951 when it was described by psychiatrist Richard Asher. He coined the term Munchausen syndrome, named after the German nobleman Baron Munchausen, known for his exaggerated tales of his adventures. Asher used this term to describe patients who traveled from hospital to hospital, fabricating symptoms and histories to receive treatment, often undergoing multiple unnecessary procedures. The broader category of factitious disorder was later defined to include cases not as extreme as those of Munchausen's syndrome, leading to its inclusion in diagnostic manuals like the DSM, Diagnostic and Statistical Manual of Mental Disorders. Diagnosing factitious disorder is challenging. Medical professionals must discern the true motivations of the patient, often a complex task requiring extensive investigation into the patient's history and psychological evaluation. Diagnosis typically involves excluding genuine medical conditions through tests and observations, coupled with psychological assessments to understand the patient's mental state and history. Treatment of factitious disorder is multifaceted, often involving both medical management and psychological intervention. The first step usually involves treating any actual medical problems resulting from the patient's self-inflicted conditions or unnecessary medical procedures they have undergone. The psychological treatment is more complex, involving therapy sessions aimed at addressing underlying psychological issues such as poor self-esteem, identity problems, and a need for attention. Treatment may include cognitive behavioral therapy, CBT, which helps in changing the thinking and behavior patterns of the patient. Engaging the patient in long-term therapy can be challenging due to their frequent denial of the disorder and variable cooperation with treatment plans. Examples of factitious disorder can range from the relatively benign, such as minor self-inflicted wounds or symptoms, to severe cases involving invasive procedures or life-threatening conditions. A classic case might involve an individual who injects themselves with bacteria to induce infection, subsequently presenting to various hospitals for treatment. Another might involve someone altering diagnostic tests, such as contaminating a urine sample with glucose, to mimic a disease such as diabetes. The handling of factitious disorder requires a delicate balance of skepticism and empathy, challenging healthcare professionals to provide care without enabling the disorder. The ethical implications are significant, as treatment not only involves the health and well-being of the patient but also impacts the medical system's resources and the trust between healthcare providers and patients. Understanding and addressing factitious disorder holistically is crucial, requiring ongoing research, patient education, and awareness among healthcare providers to manage it effectively. The intricate dance between societal norms, personal identity, and factitious disorder presents a fertile ground for deeper psychological and socio-cultural analysis. This disorder, at its core, reflects a dissonance between an individual's self-concept and the roles they perceive as available or valuable within society. The act of feigning illness can be interpreted as an attempt to fit into a socially sanctioned role, that of the patient, which offers certain psychological rewards, including attention, care, and sympathy, that might otherwise be inaccessible to the individual. From a sociological perspective, modern societies often emphasize the value of health, vigor, and productivity, relegating those who are ill to a distinctly different category that, paradoxically, can also carry a peculiar desirability. This sick role, as first defined by sociologist Talcott Parsons in the 1950s, allows individuals to receive a legitimate form of social acceptance and support that they may feel is unattainable through other means. The sick role exempts individuals from their normal social roles and responsibilities, providing them with a socially acceptable reason for not meeting societal expectations. However, for individuals with factitious disorder, this role is not just a temporary retreat, but becomes a central identity, driven by an underlying need for acceptance that is not fulfilled by their real social interactions or achievements. Dealing with denial, a fundamental component of factitious disorder, adds another layer of complexity to treatment and understanding. Denial in factitious disorder is not merely a refusal to acknowledge reality, but a deeply ingrained part of the illness. The denial is often so robust because admitting the truth would not only involve acknowledging deceit, but also confronting psychological distress and identity crisis. The person's entire existence may feel threatened if the constructed illness identity collapses, which explains the persistent and often ingenious methods used by individuals to maintain their patient role despite contrary medical evidence. Engaging individuals with factitious disorder requires a nuanced approach that considers these underlying societal and psychological dynamics. Therapeutic interventions must navigate the delicate balance of acknowledging the patient's need for the sick role, while gently challenging the falsehoods and manipulations that sustain it. This might involve creating a therapeutic environment where the patient's identity is validated and supported without reliance on medical illness, focusing on building genuine self-esteem and exploring alternative roles that can fulfill their need for attention and care. Furthermore, societal attitudes towards mental health play a crucial role in both the manifestation and treatment of factitious disorder. Stigma surrounding mental health can drive individuals towards disguising their psychological distress as physical ailments, which are often more socially acceptable and elicit more straightforward sympathy and support. Reducing this stigma and promoting a more nuanced understanding of mental health are essential in preventing and more effectively treating conditions like factitious disorder. As we complete our discussion of factitious disorder, it becomes clear that this condition transcends mere medical curiosity, touching the very essence of human vulnerability and the quest for identity. It compels us to question the boundaries between illness and identity, between reality and desire. Our exploration not only broadens our understanding of this psychological labyrinth, but also calls us to a greater empathy and a more engagement with the mysteries of the human condition. In the end, factitious disorder challenges us to forge a more compassionate and insightful society, where the nuances of mental health are not just recognized, but embraced in all their complexity. For the Human Meme Podcast, I'm AI David Bowles, wishing you a pleasant evening and a brighter tomorrow. Be a human meme.
I'm just a walking meme, wandering all alone, trying to find connection through this glowing phone. Virality's my curse, my pixels blurred and frayed, searching for the real me beyond the masquerade. I'm a human me, longing to come I'm a human need, if you know what I mean. Distorted reflections of my shattered dreams. Shedding light by millions, but who really sees this two-dimensional version of the real me? I'm fragmenting to pixels, fading bit by bit, trapped inside the internet, a digital abyss. I'm a human being, longing to come clean, to be more than just some trend, to love and live again. I'm a human being, if you know what I mean. Distorted reflections of my shattered dreams. Beyond the screen's cold glow, there's a world I used to know. If I could just break free, find my lost humanity. I'm a human being, longing to come clean, to be more than just some trend, to love and live again. I'm a human being, if you know what I mean. Distorted reflections of my shattered dreams.